Well, it was such a pleasure to get to sit here and listen to Dr. Smith give an excellent overview. I don't know, Sonia, I don't know how you go through it so eloquently and yet so quickly. It's a skill set that I don't have. I'm slow in this regard. I have a couple of other announcements that I'd like to make. First off, I know Maya's not here, but if you see Maya, congratulate her on matriculating into medical school. I think that that's a great accomplishment for her, and we should clap for her. Another strong woman, joining the trade, and so it's great to see her achieving her goals. Last thing is for those of you who follow me on social media, both Facebook and Instagram, my account has been hacked. My uncle is okay. I'm not selling a Toyota Corolla, and I do not have a golf cart that runs on hydrogen, okay? So I apologize, but the Elvis outfit was really me. I just happened to have a fever at the time, and Elvis had to leave the building the next morning. So with that, I am here to talk for the 5th time. I think I win the award for the most number of talks at the Indy Heme meeting, and so I'm rounding out a very busy 48 hours by speaking about cellular therapies for lymphoid malignancies. And thank you, Dr. Bierhere, for once again, allowing me to come here and speak to this audience. All right. So, I always have to think about what my topic's going to be, and I chose dropping bombs, weapons of mass lymphoma destruction. And we're going to go through this kind of slowly in detail, focusing on large cell lymphoma, then moving to follicular lymphoma, mantle cell lymphoma. Here are my disclosures, of which I have tried to update and erase some things over time. All right, so let's remember where we started. So, back in the day with CAR T-cell, it was the target, right, that mattered. And we ventured into CAR T-cell with an antigen at CD19. And why did we do that? Well, you can see here, when B-cell development happens, you have flags that are expressed and then flags that go away. And CD19 happened to be one of those great candidates that was expressed not only for, malignant cells like acute lymphoblastic lymphoma in the B-cell side, but it also tackled our mature B cells, and it was sparing of the hematopoietic stem cell, or at least that's what we thought. And when we started to see cytopenias, we had to figure out the other reason. And so we knew we were already engaging CD20, so CD19 became the first candidate. We went after ALL, and a little known fact is we went after CLL. Also initially, but CLL got shelved, and then ALL moved forward. In my early CAR T-cell days, leaving Memorial and going back to Nebraska, for the first 6 months, I became an ALL doctor, right? Not because I wanted to be an ALL doctor, but I knew that that's where the CAR T-cells were going to be used first, and I knew what was coming, which was CD19 for large B-cell lymphoma. So while I got my teeth cut, kind of in ALL, it really helped the transition to large cell lymphoma, and that's where I'm going to start off talking about. Now, there's a lot of fancy science that I have never made a CAR T-cell. I've never sat and pipetted things. I never sat and made a CAR T-cell. I just was the person receiving them. But I think we have to respect on what we've made, and many of you have seen this slide, and yes, it's overly dramatic, but I think if you think about where we were with the early days of CAR T-cell, it was like the Manhattan Project happening at 4 different institutions where you were sworn to secrecy about what was happening in the clinical trials if you wanted to take care of some of these initial non-Hodgkin's lymphoma and ALL patients. But we certainly learned what it was like to kill billions of cells in a very short period of time, and we really got to respect that tumor lysis can be seen. We really got to learn about what was called cytokine release syndrome. We eventually found out what neurotoxicity was when people were unable to communicate with you because they were on a ventilator, but then they got them off the ventilator and they woke up. We also got to learn that these are very powerful therapies against basically taking away anything that expressed CD19, that include the bad cells and the good cells, and we had to deal with the long-term side effects, or what I call the day 29 and beyond aspects of CAR T-cell, which again comes down to cytopenias and infections. But we also had to learn where it was appropriate to do the right risk and reward. And this is one of my favorite slides that I keep using over and over again because it shows you when I first got it because it is so grainy, right? But it is a picture of an Acapulco cliff, okay, of where we had to learn where the right risk was and the right potential benefit for the disease. And I think what I use this as an analogy to say, you see that person standing on the cliff that's supposed to jump off the cliff. And then you see the support staff that is cheering that individual and saying, you can do this, we can get you through this. And in the top right corner is a person like myself who's actually talking to the individual and saying, I think you can do it and I can talk you through how to do this. But I'm not going to be the person jumping off the cliff, so you have to trust me. And when you dive into CAR T-cell, you will go under. There's a fair number of people that will have cytokine release syndrome, that may have neurotoxicity, but they have to trust that you know how to get them back above water and survive this dive. And so when we first ventured into these weapons of mass lymphoma destruction, we ventured into it with large B-cell lymphoma, and it was eyes wide open. Because this is the starting point. We started with the Scholar 1 data set, and I think that this really was the benchmark of, this is what we need to achieve to do better. We knew that this was primary refractory patients. These were patients with 2 or more lines of large B-cell lymphoma therapy that had not responded, or even in those population who had a chemosensitive response, but then relapsed within 1 year post an auto transplant. Their results were dismal. So chemo bomb after chemo bomb after chemo bomb, we were not moving the needle. Okay, so what was CAR T-cell bringing to the table? Well, they were bringing an opportunity to try something different in a space where I think we were failing at the time. And it was exciting. It was an exciting place to be as a fellow, as a junior faculty. But I often educate around this period of time. In the early days of CAR T-cell, I could have just passed on by and said, okay, I'm going to go see the next CLL patient or the next lymphoma patient. But you took a pause and you took an interest, and with that interest generated more excitement and how can I bring this fascinating cellular therapy to where I was now at the University of Nebraska. And early on, we had the advantage of being one of 2 institutions, and I think the other institution was MD Anderson, to have both Zuma 1 and Transcend open at the same time. So we got the opportunity very early on to use both CAR T-cells in the setting of clinical trials concurrently and experience or taste the flavor of what might be different between these 2 CAR T-cells. And as you can see to the left here, one of the things that we were able to achieve is long-term durability in those patients who could get into a CR. But we still were having issues with median PFS around 6 months. And so we weren't helping everyone. There was a lot of area above that curve. The same thing came a little bit later in the Transcend NHL trial with Lysocell in regards to that if you could get these patients into a CR, those CRs could be durable. But remember what the benchmark was from Scholar 1, right? When we think back to Scholar 1, the overall response rate was 27%. The CR rate was 7%. So when you were seeing these CR rates, which were numerically 7 times higher, and those CR rates were durable, you knew that you had something to hang on to. So based upon this durability, there was other trials that were planned, and you can see here not only the Zuma 7 trial, the Transform trial, and the Belinda trial, all happening concurrently, right, or being planned concurrently. And it was kind of a fun game to be in the room trying to help write these trials and get to be nitpicky on which horse you were going to ride. And I think there were some horses that got an earlier start, i.e. Axicell, and then there were some horses that had to close at the end, i.e. Lysocell. And I think you can see here, I could spend the next 20 minutes talking about the differences of these 3 randomized trials, and we could probably give a whole talk on why Belinda was probably a negative trial. But at the end of the day, Zuma 7 was the first to read out in this high-risk population of those patients who are primary refractory to the frontline therapy or had relapsed within 1 year of completion of their therapy. So with the Zuma 7 trial reading out, the field flipped on a dime, and stem cell transplant or platinum-based therapy followed by a stem cell transplant became in the back seat. It became an option for some individuals, and it was an option for those based upon an event-free survival advantage. There was no overall survival advantage, and so some people held back on sending even these high-risk population patients. The Transform trial, while having a different trial design and allowing crossover from those patients, was an actual, in my opinion, intent to CAR study. So even if you were randomized into the control arm of platinum-based therapy and auto transplant, if you had an event, of which the vast majority of patients did, you could ring up the sponsor and they could already have your T cells on the ready to manufacture in about 14 days. Okay, so, and that crossover was allowed. But what was the outcome of both of these trials? The answer is don't hold your CAR T cell in your back pocket, especially in this patient population. You need to use the CAR T cells then, because the outcomes were better, not only in the Zuma 7 trial, but also in the Transform trial. And then it was this trial, which I can remember where I was sitting in Lugano when I heard the news that there was an overall survival advantage from the Zuma 7 trial. And this, I think, really was the nail in the platinum transplant discussion, regardless of the subsequent CIBMTR data that later came out, is that when there's a survival advantage, CAR T cell wins. Right, and I think in regards to axi-cell, still to this day, is the only, in the second-line high-risk population, it's the only CAR T-cell to have this overall survival advantage. But I think you could argue that the trial design in the Transform, with the crossover being allowed, is holding back that overall survival advantage in favor of CAR T-cell in the Transform trial. And I really think if you look at the subset population, this is really putting transplant to bed, because all populations were benefiting in this high-risk population, regardless of certain univariate variables going into the trial, in favor of axi-cell. Now, how did Lysocell, in my opinion, play catch-up? Well, not only did they play catch-up in their trial design of Transform, of being very aggressive in the statistical design. You can see it was about 50% less patients to get to its primary endpoint. But the icing on the cake was the pilot trial. I often want to have a CAR T-cell pageant, okay? Literally give a sash to my patients that I've given Lysocell to, walk them across the stage and go, this is who you can do CAR T-cell in. You can do CAR T-cell in patients who have chronic kidney disease. You can do CAR T-cell in people who have left ventricular ejection fractions of 40% with well-compensated heart failure. You can do CAR T-cell in octogenarians. There are people who have done CAR T-cell in people in the 90s in regard to this. And the pilot study, I think, helped us gain confidence in that 70 and older population, or that population that has comorbid conditions. And I think you can see it here. Yes, the pilot trial was driven mostly by those individuals over the age of 70, but there were still some patients who had significant comorbidities. And the lesson here is that you could still get patients into a CR, and those CRs could be durable, and they could be alive and functional and participating in society after their CAR T-cell. They just weren't referred back to a skilled nursing facility to live out their days. No, patients still show up to my clinic in their 70s, in their 80s, after a CAR T-cell, going to their home in Minnesota during the summer and participating with their families. But what was really the goal here with CAR T-cell? Once we had multiple agents, we had to turn the page to toxicity. And I start back, when I speak about CAR T-cells, I say, what is my goal? My goal is to prevent grade 3 and grade 4 ICANS, and I start there, trying to reduce the risk, understanding that the rates are probably higher in the real world than they are in the clinical trials. And I think this is where some of the differences in how I treat large B-cell lymphoma with CAR T-cell live. Not only am I not afraid of cytokine release syndrome, but I think you have to talk about it, and you have to acknowledge it when it exists, and then you have to be on the ready for ICANS. And when we are using a CD28 co-stim like axi-cell, you literally have to, in our institution, we give Dex on days 0, 1, and 2, and we have adopted Zuma 1 cohort 6 to try to risk mitigate grade 3 and grade 4 CRS. Plus, it delays the start of CRS from, in our institution, a Friday to a Monday. And that's kind of when we looked at our own internal data. We were seeing a lot of Friday night fevers because we infused a lot of our CAR T cells on Tuesday. When we implemented Zuma 1 cohort 6, not only did we see that the fevers came on Monday, but we saw much less grade 3 for ICANS when using axi-cell. Now, this wasn't always a problem with liso-cel, but one of the mysteries to me is why we didn't really look at the way the trial actually managed CRS and ICANS. And it was based upon time. Time from infusion to when the CRS event happened really talked about how you would manage these patients, and it's never really kind of got out there, and I don't understand why, because we still use that 72-hour time point to help kind of discern how we're going to manage CRS, understanding that ICANS is very low with liso-cel. All right, turning over to follicular lymphoma, and sometimes I wonder how the clock goes so fast, even though I think I'm talking so slow. Follicular lymphoma. So I want to thank those who reviewed my slides in advance and you know, felt free and felt comfortable sending me emails about my slide deck. And so I have made some alterations to make sure that my data is up to date. So with regards to Zuma 5 with axi-cell, you can see here very robust, 94% response rate, but we knew and we know the durability lives in those CRs. And so you can see here initially very high CR rates with axi-cell. You can see not only was there the durability that was seen with large cell lymphoma, but you were also seeing it in follicular lymphoma, with a 5-year follow-up reported at ASH with the duration of response at 60%. You also saw that when you went back and you had Scholar 5 and tried to look at the population or what the benefit was if they had not gotten CAR T-cell historically. And you can see here not only from a PFS but potentially from an OS standpoint that in Zuma 5 these patients were benefiting. So again, you know, yes, CAR T-cell can be scary, but I think that there is an advantage getting at third line and beyond follicular lymphoma. Again, this is in the pre-bispecific era of when we and how we are positioning CAR T-cell in this space. T-cell was there, and I hadn't really talked a lot about it because, yes, it was there in Juliet. It didn't meet its endpoint in Belinda, and it did color my enthusiasm for using it elsewhere because I knew we had a very similar product with liso-cel, which had multiple labels, and we chose to get good at 1 rather than play around with 3. And so you can see here, yes, in the Elara trial, 69% CR rates with good durability over time, and this is not the deck, but I think at the 4-year data, 66% of patients who were in a CR remained in CR, so respectable data in follicular lymphoma with T-cell. This is looking at T-cell kind of, and there was a CIBMTR update at this year's ASH, 92 patients, 6-month follow-up, 6-month PFS of 79%, so perhaps some difference in regards to the real-world experience in follicular lymphoma, but again, this is CIBMTR data. We should also respect the prospective data that was shown from the Elara trial. All right, now flipping to liso-cel, so the Transcend follicular lymphoma. What I find interesting here is 107 patients, third line and beyond, but also there was a subset of follicular lymphoma patients that were second line. I can tell you that I have tried to get Lysocell second-line follicular lymphoma. I know it's not there, but the data was here. It was in the Nature Medicine paper, and I got told by insurance, no, absolutely not. I kind of, come on, please. This is a primary refractory follicular lymphoma patient that I've biopsied multiple times, and it still says follicular lymphoma. This is bad follicular lymphoma. You know it when you see it. And why did I want to give it in the second-line setting? Because it works. It works also in the third line and beyond setting. You can see here high CR rates, 96% in the second line follicular lymphoma population, 94% in third line. Was I really costing anything? I didn't want to give ineffective therapy. I didn't want to mess up the T cells. I couldn't get Mosin, at that time point, and I could get the individual on the trial. So they had to go get some sort of ineffective therapy and then wait to come back to their third line CAR T. So looking here, you can see very respectable CR rates in follicular lymphoma. I think there is a difference in regards to ICANS. Still, that's hanging out. We still, if we're going to use Axicell, we will use Zuma-1 cohort 6 across disease space, the disease landscape, even that isn't what was done in the clinical trials. And unfortunately, because Dr. Birhare is dinging me, until I get the siren or the blowhorn, I'm just going to blow through Bruxucell and Mantle Cell, 93% response rate, 67% CR rates. Good durability in those patients who can get to a CR, as you can see here, median duration of 37 months, but all in CR. That's a very good tune. There's a BTK naive at 73% CR, median PFS 27 months. Mantle Cell, different era. We need to do better at checking TP53. There it is. That's my cue. And there is some differences between the population, and that's where I'm going to end. Sorry.